Good evening and welcome everyone. I, Dr. Ritika Dhiman, on behalf of Voice of Healthcare, welcomes all the speakers and the viewers who have joined in for this cardiovascular virtual roundtable organized by Voice of Healthcare. In this discussion, we will be discussing the latest guidelines for managing hypertension and high cholesterol, as well as the most promising and emerging treatment modalities for heart failure. We will also be discussing the potential impact of cardiac devices on patient outcomes, including their ability to improve survival rates, reduce hospitalization, and improve quality of life for patients with cardiovascular disease. So let's begin our discussion by the introduction of our keynote speaker. I welcome Dr. O.P. Yadava, CEO and Chief Consultant, Cardiothoracic Surgeon, National Heart Institute. Welcome, Dr. Yadava.
Thank you.
Over to you, sir.
Well, good day, ladies and gentlemen, and thanks, Ritika, for giving me this opportunity. And I compliment and felicitate the Voice of Healthcare for this wonderful cardiovascular virtual roundtable. You have an absolute galaxy, a starlit, what shall I say, faculty. So I'm not going to go into the individual details of the topics that you have carefully chosen, the emerging and the existing cardiac devices, as well as the latest hypertension and cholesterol guidelines. But I'd like to make a few generic comments. Mechanization virtually has percolated through every facet of life. You have data being generated at every occasion, be it when you use your credit card, when you visit the hospital, from the monitors, from the wearables, from the sensors, from all kinds of imaging. And this data collected together goes under the terminology what we call the big data. And this big data, properly analyzed, can be used for predictive analysis. It can be, used very usefully for point of care testing, for accuracy of imaging, and for better diagnosis. It is cost effective. It can be taken to remote areas. It can be used for monitoring, for surveillance. It can be used as an incentive for better health. And in a country like India, where disease prevention and promotion, health promotion is more important than treatment of disease, this could be revolutionary. It can be used in drug discovery. We saw that in the corona pandemic. The vaccines came up at warp speed. Then, it is important for remote sensing and monitoring. So telehealth, domiciliary care, administrative functions, all this can be done through artificial intelligence and technology. And such exciting things as virtual and augmented reality, deep machine learning models. If you combine blockchain with artificial intelligence, I tell you, the possibilities are immense. In fact, we are not talking of not just Internet of Things, we are speaking of Internet of medical things. So, so much is going on, and there is virtual explosion of technology. One estimate puts it that it's going to have a compounded annual growth rate of 47% over the next 5 years. From 14 billion, this technology segment will grow to 100 plus billion US dollars. So that's all phenomenal. In the field of heart also, and circulatory system also, mechanical circulatory support has come up in a big way, but the biggest problem with it, the way I see it is, number one, patients are being referred late. Ritika just referred to how we improve results by use of these technologies. But the patients are being referred late. Now, partly because of the fiscal and the economic imperatives in a country like India. Also, we find that the centers dealing with this high-end technologies are not freely available. They're few and far between. Those are important factors. But the most damning is the lack of sensitization of the medical professionals that these technologies are worth using, as well as lack of confidence on the part of the patients on these technologies. And that is really hurting the cause. Because if you really look at the real results, today we are using mechanical circulatory support as destination therapy with results approaching, not quite, but approaching those achievable with heart transplant. The another big point that I have some kind of element is that whenever a new technology comes, suddenly the whole fields get crowded with that technology. More and more people join in. But in mechanical circulatory support, reverse is happening. We only had 2 or 3 players, and in 2021, 𝗘𝗚𝗑𝗧 left the field. So we are left with the monopoly of only one HeartMate 3. And that's not good. I don't like that. Any monopoly brings in complacency, it brings in stagnation, it brings in exploitation, and it is very antithesis to innovation. So we need competition in this field very badly. And thirdly, we must learn from, even though 𝗘𝗚𝗑𝗧 has demised, but it has taught us the value of continuous data, of log files. You can diagnose tamponade, you can diagnose right heart failure. So those important lessons from that technology must be built going forwards, and we must have more competition in the field. So that is extremely important. Moving forwards, we're going to have new materials. We are going to have transcutaneous transfer of power. Already they are becoming miniaturized and they are becoming fully implantable, and use of continuous flow technology has surpassed the pulsatile technology. But these will need further, improvements. But the ultimate answer will come when we have a total paradigm shift, when we are able to repair the damaged myocardium using cellular, molecular, and genetics, and those kind of paradigms which are going to be totally disrupted. So, ladies and gentlemen, my best wishes for the success of this roundtable, and hope we are able to generate data and guidelines for our colleagues in the far-flung areas of the country to use. Thank you very much.
Moving on to a virtual roundtable, I would like to introduce our lead moderator for today. I welcome Dr. Vivek Jawali. Dr. Vivek Jawali is presently the Chairman, Cardiac Sciences and the Executive Council of Fortis Hospitals, Bangalore, and the National Chairman, Cardiovascular and Thoracic Surgery Council, Fortis Healthcare Limited, India. Dr. Jawali has been the president of the Indian Association of Cardiovascular and Thoracic Surgeons since 2008. He is the founder member of the International Society of Minimally Invasive Cardiac Surgeons and is the only Indian on the editorial board of its journal, Innovations in Cardiac Surgery. He is also the council member of the Asian Association of Cardiothoracic Surgeons. So I welcome Dr. Jawali.
Thank you.
Over to you, sir.
Thank you, Ritika. Thank you very much. So welcome to this panel discussion by Voice of Healthcare. It's being watched by doctors and healthcare managers across the country. These topics of this will range from hypertension, recent advances in management, lipid management, to heart failure, devices in heart failure, and the surgery for heart failure. So let's open our discussion with Dr. Shoeb Nadeem of Nagpur, ALEXIS Hospital, consultant cardiologist. Shoeb, let's start off with you. Let's start with hypertension first. So I want to ask you first question for the audience to know that this ambulatory blood pressure monitoring versus home blood pressure monitoring for hypertension, its diagnosis and treatment, and also some comment on fixed dose combination, efficacy versus compliance.
Yeah, so sir, actually being a clinician, we come across hypertension as the most common cardiovascular disorder probably. Now, there are various challenges in hypertension management and diagnosis both. As we see, office BP has not been very clearly correlated with the cardiovascular outcomes. That is the reason why ambulatory BP and home based blood pressure monitoring has been advocated. Now there are things like masked hypertension, white coat hypertension, sustained and non-sustained hypertension. So there comes the role of ambulatory blood pressure monitoring, because we see few people who have high office BP. While you monitor them with ABPM or HBPM, they have got normal blood pressure, that is white coat hypertension. Those patients are at lesser cardiovascular risk as compared to the ones who have sustained hypertension. Similarly, masked hypertension, where in the office BP may be normal, but the ABPM or the HBPM may show high BP. Those patients are important because those have got high cardiovascular risk. Now, ambulatory BP monitoring, we all know, is performed by applying the instrument and patient goes home, ambulates. So, advantage of ABPM over HBPM is that we get readings in the ambulatory settings, number one. Number two, nighttime readings are also available. So, precise diagnosis of hypertension probably we get with ABPM. Also, HBPM is very important because ABPM is only for a fixed 24 hours dose duration, while HBPM home-based blood pressure monitoring can be done over extended periods. A patient can themselves monitor the BP, as well as the BP monitoring is guides you in your further treatment as well, apart from diagnosis. So typically an average 24-hour blood pressure more than 130 by 80 on ambulatory blood pressure, or daytime blood pressure more than 135 by 85, or a nighttime blood pressure more than 120 by 70 is what defines as hypertension in ambulatory blood pressure monitoring. And in HBPM, which typically involves like before office visits, 3 to 7 days prior to the office visit, patient takes blood pressure after 5 minutes of relaxing in the sitting position, and takes two readings at least 5 minutes apart. Those averaged readings more than 130 by 80 defines hypertension. So I think both of the things have got role and both have got positive and negative aspects. There is important thing like nocturnal dip in blood pressure, and those who are non-dippers have got high cardiovascular risk. So ABPM is a better way to diagnose the nocturnal dippers as well as the morning surges.
Okay, a
Uh,
short note from you on
yeah,
this fixed dose combination in the treatment,
yeah.
efficacy
So
versus compliance.
okay. So now this has been the guidelines. This has been recommended that single pill combination is definitely far more better than isolated drugs. Whereas trials as well as meta-analysis have shown that almost 70% of the patients with hypertension are being undertreated, or they are not achieving target blood pressure. So with combination dose, the compliance increases. That is quite natural, as well as studies have shown almost 28% better control of blood pressure with single pill combination. So the latest guidelines, they themselves advocate use of fixed drug combination as the initial therapy, because most of the blood pressure hypertension patients do require two or more drugs to start with, especially when the BP is more than 150 by 90. So I think the studies have also shown us, and it is a common practice to give single pill combination over and above the normal pills taken differently.
Okay, thanks a lot, Dr. Nadeem. What we will do is we will run from current concept to current concept and not waste time in basics for the benefit of our audience. Let's go to
Yes.
Bangalore. Dr. Sunil
Yes.
Dwivedi is a senior cardiologist at the Manipal Hospital in Bangalore at the Millers Road. Sunil, welcome. The question for you is about the lipid management. There are these new hypolipidemic agents like bempoic acid. What's the current practice norms and role of this PCSK9 in diffuse atherosclerosis? Can we use it routinely, particularly so after these recent trials?
Yes, sir. I think these are the newer agents, or rather, you can say PCSK9 inhibitors has been there for a longer time. Bempedoic acid in clinical practice has come recently. as far as the decision is there that rather than using routinely, we should use them frequently as an adjunct or as a independent agent also standalone. See, the issue is about statin intolerance or statin ineffectiveness in controlling the LDL level. We know that there are very well target defined by either European Society of Cardiology or ACC about in which situation what should be your lipid targets, especially the LDL, to reduce atherosclerosis in various vascular beds. So what has happened is that those targets are pretty stiff, and the routine dose of statin will not help in reducing those LDL levels. So the maximum tolerable dose of statins are given. Now, there are few scenarios where this will not be effective. One, that the liver production of LDL is high, so the maximum dose of any given statin is not enough to reduce the LDL level. Second, the patients get statin intolerance, partial or complete, where even mild dose patient cannot tolerate, or high dose they don't tolerate. A lot of myopathy, which includes myositis, also can happen. There is third category where familial hyperlipidemia. So in this situation, the effect of statin is much poorer. The results are much poorer. There is the use of these adjunct therapies, which have become right from the fringes. They have come into mainstream. The older one molecule is PCSK9 inhibitor. It's an injectable drug. So as we know, PCSK9 enzyme causes the lipolysis of LDL receptor in the liver. So the liver cannot suck out the LDL from the blood and then take it for metabolism. So PCSK9 inhibitor monoclonal antibody increases the level of LDL receptor. These are injectable drugs given at once in a month at 420 milligram or twice in a month at 140 milligram. That commonest one which is available here, evolocumab. So these drugs help in achieving the LDL reduction target in patients who are either having maximum dose of statin, or statin intolerant, not getting maximum dosage, or in familial heterozygous hypercholesterolemia, which is very difficult to achieve by these drugs. In homozygous hyperlipidemia also, they are partially effective. The issue has been the cost in injectable mode of therapy. But the trials like Korea trial, Odyssey trial have shown that in very high risk patients where there are atherosclerosis, multiple vascular bed, and within 2 years, patient has one acute vascular event, whether it's in coronary or any other vascular bed. And so these are the cases where if you put them on PCSK9 inhibitor and bring it down to very low, below 45 LDL, then the reduction of vascular event is very well evident over a period of 2 years. In acute MI situation, also Odyssey trial has shown a lot of lipid reduction, but in clinical event, it has to be shown there is a significant reduction or not. Now let's come to the newer kid on the block, bempedoic acid. This is an advantage, I said, tablet. It's like ezetimibe, which we have had earlier, which was very useful, then went into oblivion, then come back again. Ezetimibe reduces the absorption of cholesterol from the intestinal epithelium, but this bempedoic acid works in the production chain of the statin. HSG coenzyme A reductase inhibitor is the statin. Two steps above it works, and it's a prodrug. So it gets active in the body after metabolism in the liver, and there is hardly any enzyme which metabolizes in the muscles. So the advantage is that in a very minimal myopathy, works two steps higher in the chain where statin work, and it gives additional 30% reduction standalone. So this has come as a good substitute or good accompaniment to statins in various situations, and you can give 180 milligram per day as a tablet. So easy to take. The cautions for bempedoic acid are that uric acid and gout are slightly higher, and then incidence of tendon rupture of biceps or tendo-Achilles are bit higher, especially people who are on steroid, fluoroquinolone, or renal failure, or on high dose of statin. So, barring these two things, bempedoic acid is a very good drug which should be used frequently to achieve our designated
Thank you.
target of LDL reduction.
Right, Sunil. What we will do, the plan of our discussion is that we will quickly shuttle between you and Nagpur and talk about some medical questions and then we will go to Delhi to Kler Saab to have a little detailed discussion on devices. And from there, we'll move on to the surgeons to talk on the current concepts in surgical practices. So back to you, Sunil, again in Bangalore, that how do you foresee for, now we go to heart failure, how do you foresee the role of newer agents like the Vericigot in addition to those four standard pillars, beta blockers, ARNI, the SGLT2 inhibitors, and aldactone? How do you see this?
Yeah, very good, sir. The as we know that in a recent time, the medical management of heart failure, the cornerstones of therapy, medical therapy, four drugs. We start with beta blocker and SGLT2 inhibitors, and add ARNI, that is sacubitril valsartan, and then add MRAs, that mineralocorticoid receptor antagonist. Within 4 weeks, you start all of them, then escalate the dose. As compared to earlier ACE inhibitor, beta blocker, you start, then once escalate the dose. Now, Vericiguat has come because there is still unmet need in medical treatment, where patients will be there with heart failure with reduced ejection fraction, where there will be recurrent heart failure, deterioration of the heart function and the clinical status, as well as recurrent acute decompensated heart failure. So, Vericiguat, it acts on a different level. This is a soluble GMP stimulator. So independent of nitric oxide, it can stimulate the endothelium and cause vasodilation, and a lot of negative effect of antioxidant it reduces, and it has a partly natriuretic property, also very weak indirect. So uh, when you give this medicine in the Victory trial, it was assessed that patients who are already on IV diuretics, or who had a recent heart failure within 6 months, whether it was a worsening of heart failure or whether it's acute decompensated or de novo, if you give drug which is the dose ranges from 2.5 milligram to start and goes to 5 and 10, if you give that, the recurrent hospitalization with heart failure comes down. The mortality reduction is not significant. Now, this was a trial. Now, a lot of small studies are coming and experience which says that you can initiate it early rather than giving all these four drugs and then waiting for a heart failure event to occur on all these standard four therapy, where you start early along with these things and you will reduce that. But I think for that we need more data. That's what I know, but it's a very promising molecule, barring a little bit of cost and availability. But since it's an oral and once a day drug, I think it could be a very good add-on for a reduction in recurrence of heart failure hospitalization.
Okay, Sunil, thanks a lot. Now
Thank
let's go back to Nagpur to Dr. Shoeb, Nadeem, and few questions again. Nadeem,
Yes.
what are, according to you, the limitations in current heart failure therapies and challenges faced day-to-day practice in medical management?
Yes. So actually, heart failure being a diagnosis, it affects the complete life of the patient. It is the one diagnosis where patient has to live for quite a long time. Patients live with heart failure. Now, the problem that we face in day-to-day practice starts from the diagnosis till the management and rehabilitation. Now, I work at a multi-specialty hospital, and I frequently encounter patients who come to me after they being symptomatic for at least 6 months to an year. So, referral to a specialist, especially those people who live at remote areas, many a times they are being treated with bronchodilators, with derifilins, misdiagnosing as probably an asthma. There are incidences where they even are being treated by gastroenterologists, especially in chronic heart failure, where they have just abdominal fullness. So many of them are being treated as some gastric problem. So the challenge starts from diagnosis itself. So I think there should be more awareness amongst the physicians regarding, although heart failure is a clinical diagnosis, does not usually require a specialized test or care. But then still high index of suspicion is needed, especially in chronic heart failure patients.
Thank you.
Yeah.
Right, right.
So
Then,
uh, as far as the management protocol is concerned, now as Dr. Dwivedi has already talked about, in our armamentarium, we have got 3 or 4 new drugs in last 5-6 years, which has probably brought in a paradigm shift in management of patients. Now we see better quality of life with medical management, especially after ARNI, SGLT2 inhibitor, and now Verisuagon. But
Do
still
you
there is an
underline
unmet.
the importance of rehab programs or even
Yeah,
remote controlled software based modern rehabs which can be done
yeah.
online?
So I was coming to that. That once the patient is being treated, many of them are lost to follow-ups. Many of them are residing in remote areas and they don't have a regular follow-up visits. So there should be a plan for a specialized heart failure clinic. There should be some telemedicine program where patients are being routinely kept in contact. A specialized nurse or a junior doctor keeps in touch with them, ask regularly about their weight gain, about their fluid intake, about their compliance to medicine, and need to go to the hospital whenever there are red flag signs which come. So I think rehabilitation, telemedicine also has got an important role.
Thank you, Nadeem. We will go back to Bangalore. We will go to Dr. Sunil again. Sunil, one last question to you. Personalizing the therapy, the optimal medical management of heart failure. What is the role of various imaging modalities and genomics to personalize
Sir,
the treatment, customer care?
mainly this comes into, cardiomyopathy is much more where, like hypertrophic cardiomyopathy or restrictive cardiomyopathy, or you can say imaging, I'm talking, and so then the infiltrated one. So cardiac MRI has come into very much into picture where it improves the diagnosis, especially, sarcoidosis, myocarditis, and infiltrated disorders like, hemochromatosis. This is where we stand. And if you take hypertrophic cardiomyopathy, or if you take dilated cardiomyopathy, the extent of fibrosis also determines the prognosis in many situations. Even if the left ventricular ejection fraction is more than 40%, the patient is an NIH class 2 or 1, where the more the fibrosis, the more the chances of sudden cardiac death. This is more so relevant in hypertrophic cardiomyopathy, where when the exact diagnosis is defined by cardiac MRI. Second is that you extent of fibrosis defines the prognosis, and many times, when you can define where the distribution of the hypertrophic cardiomyopathy is there, to they decide the therapy other than medical therapy. This is what the imaging, the imaging. There are a lot of imaging about myocarditis, heart phase, the PET CT you can use and make it better. And genomics basically, if sorry, I'm going to sarcoidosis. A lot of cases of sarcoidosis are diagnosed not only by the serum test AC, which are many times not positive, but just by the clinical suspicion and by imaging with cardiac MRI, where the basal infiltration is there, and you can treat the patient better. As far as genomics is concerned, still on evolving situation. Most common is hypertrophic cardiomyopathy, where variable penetrance you can use, and then there are some situations where inherited cardiomyopathy are the ones where we use genomics. The last thing is that the in in the malignancy situation where a lot of chemotherapies are being done, radiotherapy, their imaging is important to diagnose the heart failure earlier. But right now, the most important and the practical imaging is the echocardiogram only, but where you use global longitudinal strain, which is very well defined to diagnose an early cardiomyopathy because of the chemotherapy, and you can take action either by changing the therapy if possible or starting the preventive therapy like vasodilator and beta blocker earlier. So practically, it is at this stage right now.
Thank you, Sunil. Thank you very much. Let's go now to Delhi to Kler Saab. Dr. Trilok Singh Kler, T.S. Kler, is a very well-known electrophysiologist of our country. He's one of those original pioneers who separated this branch, and he has done a huge amount of interventional work, device work. Everybody knows him well across this country. He is presently the chairman at the Fortis Heart and Vascular Institute at Fortis Hospital in Gurugram and Vasant Kunj. Kler sir, welcome. The question
Thank
for
you.
you is about the newer pacing technologies, conduction system pacing versus CRT.
I say, first of all, great pleasure to be in this webinar. And uh, we all know that heart failure is a massive problem in the world, and we are going to see more and more patients of heart failure in the future. Uh, it is expected in next 15 years that the number of heart failure patients will be doubled as compared to what we have today. So we have to really kind of make our strategies very clear. Now, coming to the CRT, first of all, we all know that CRT is applicable only to those patients who have got left bundle branch block on the ECG, and the QRS is certainly more than 130 milliseconds. But CRT has not helped in broad QRS complex when there is a typical right bundle branch block. There is no trial, there is no study to show that the patient with typical right bundle, even if the QRS is more than 150 milliseconds, they really don't show a significant benefit out of CRT. So, in that regard, the conduction system pacing has come a very big new modality where we can do resynchronization with pacing the conduction system. So, either you pace the distal his or you pace the left bundle. In fact, there is only, only the conduction system pacing has shown patient with right bundle branch block almost 11% increase in the ejection fraction in those patients where QRS narrowing could be achieved in more than 75% of the patients. So as far as I'm concerned, I think the our standard of care in patient with heart failure with the prolonged QRS complex is always a conduction system pacing with or without left ventricular lead. There are many patients where we get QRS complex less than 110 or 100 milliseconds by just pacing the left bundle. Then we don't put the left ventricular lead. But if it is more than 110 milliseconds, then we do additional put a left ventricular lead so that we could synchronize. We can get the benefit of both the conduction system pacing as well as the peripheral stimulation by the left ventricular lead, because some of these patients, they have distal conduction system disease, and that is why the just pacing the left bundle may not reduce the QRS to less than 110 milliseconds. There, the addition of left ventricular lead is very useful. So, in our philosophy, any patient with heart failure who needs a CRT, we go for conduction system pacing. In about 7-8% of the patients, Dr. Jawali, we are not able to get any pacing left bundle or his bundle. Some of the patients may have fibrosis in the septum, may have difficult anatomy, but around 7-8% patients we just don't get the conduction system pacing. There we use the traditional CRT.
So selecting candidates specifically will save time and money. So
Yeah.
next question for you, sir, is about these newer therapies for heart failure, specifically role for this Bahala nerve stimulation, cardiac contraction modulation like CCM, and also any role for artificial intelligence in predicting patient responsiveness to the device therapies.
Yeah, these are, I think, very interesting questions. Uh, uh, See what happens in heart failure. So I will cover first the vagal nerve stimulation. What happens in heart failure, particularly decompensated heart failure? There is a vagal inhibition, and because of vagal inhibition, there is a RR variability decreases. There is more tachycardia. Uh, so the philosophy is that if you are able to re-establish the vagal tone and vagal stimulation. These autonomic modulation of that particular patient may help the heart failure. Well, there have been 2-3 pilot studies which showed some positive, very good positive results, but the two large studies done did not show any significant difference of vagal nerve stimulation. But what has happened is that now what we people have realized that we didn't know the dose, duration, and how to do the vagal stimulation. So now there is a very large trial going on. Uh, uh, the programming of the vagal stimulation, dose of vagal stimulation is being has been worked out, and though those studies were negative studies, but they did show how to go about it, and it is expected that the result of this large vagal stimulation trial will be available in next 1 or 2 years time. So as of today, we don't have a clear evidence that the vagal nerve stimulation philosophy works. So
Yeah.
that is about the vagal nerve stimulation. Now let me go to cardiac contractility.
Yeah.
The cardiac contractility modulation is a specialized kind of pacemaker where you have an atrial lead and you put two ventricular leads in the right ventricular septum. Here, the idea is to give a high voltage 7.5 volt stimulation on 20 milliseconds pulse width, and we have to give this in the absolute refractory period of the action potential of the myocardium. So that is usually the peak of the R wave or the descending limb of the R wave. Now the idea is, the concept is that this improves the calcium handling by the myocardium. So it does the phosphorylation of the phospholamban, and it also does the up regulation of the SERCA2A receptors, reversal of the fetal myocyte gene program associated with heart failure. So that is the kind of thinking in the cardiac contractility model. But certainly the American Heart Association ACC AHA guidelines have the FDA has approved this technology, and it is still a 2B indication. It is not become 2A indication, but now there is emerging evidence that it may have some mortality benefit, not only the symptomatic benefit. Now, people who are suitable for cardiac contractility modulation are those patients where QRS complex is normal, where they are not CRT candidates. So those are the candidates where at this time we don't have any device therapy, but cardiac contractility modulation can be considered. I did study this very detailed manner 5-6 years back, and I was very keen to bring it to India, but the cost of 25-26 lakhs put a little rider on my mind whether we are able to afford it or not. But that's the situation of cardiac contractility modulation at this stage.
Yes, sir. Then one more question I wanted to ask you, that everybody talks about Impella, and now the use is increasing of Impella. There are many patients on heart failure with an old bioprocesses in the aortic situation. Safety of Impella passing across a bioprosthetic valve or a TAVR valve.
Yeah, this is a very good question again, Jawali. First of all, I want to tell you that if any patient has a metallic valve, Impella is a contraindication. But if a patient has a bioprosthetic valve or even a TAVR valve, for example, this is not a contraindication. You can use Impella. I think in patient with TAVR or in patient with bioprosthetic valve, if it is more than 3 months of the procedure, one can use Impella safely.
Another question, one quick answer. LVAD, use of LVAD even as a destination therapy in valve-related end-stage non-operable heart failure.
Yeah, there are no large data on this subset of patients because the most of the studies done on LVAD, they are in the Western civilization, and in Western civilization, the heart failure by and large either a coronary artery disease or it is some kind of cardiomyopathy. But to best of my common sense, any region where the LV has gone bad and it is irreversible, I think there should not be any hesitation to use LVAD in these patients.
Correct.
I guess I have not done any LVAD in this kind of subset of patients, but I think if a patient is not a candidate for cardiac transplant and he has got a well pathology, severe myocardial dysfunction, irreparable or irreversible, I think one should seriously consider LVAD.
Especially AR, MR. Two more last questions, sir. One is it worth trying a mitra clip to reduce the MR in an end-stage heart failure who is waiting for getting a heart and we don't know when the heart will come? Is that a shot worth?
Yeah, you are right, Dr. Wali. These are the situations where there's a lot of finances involved, and in India, practically we are not able to do those kind of procedures because patient is waiting for cardiac transplant. It will cost him another 25 lakhs or 20 lakhs, and if we use mitra clip, is another 20, 22 or 23 lakhs. But yes, if a patient has severe mitral regurgitation, and that is contributing very significantly to the stage 4 heart failure, and the patient is for cardiac transplant, I think as a bridge, it's a good idea to clip the leaflets to decrease the mitral regurgitation.
My last question, which is again a little controversial thing which people like to know: isolated right ventricular failure, role of percutaneous therapies versus surgical RVAD, and their impact on outcome. What will be your comment?
Can you repeat your question, please, Jawali?
Isolated RV failure, role of percutaneous therapies, percutaneous ECMO, stuff like that, versus surgical RVAD, and how do you think there will be their impact in the outcomes?
Well, this is, I think, the most unexplored area in cardiology, and I would say the severe RV dysfunction is perhaps much worse than in the LV dysfunction. I really don't know the correct answer, but I think I would, if a patient has severe RV dysfunction, his LV is reasonable, I think best would be to put him a RVAD rather than anything else.
Thanks a lot, sir. Thank you. I will now take this question to our surgeon friends. Among the surgeons, let's go on to Dr. Devananda in Bangalore. Devananda is a prolific surgeon. We used to work together once upon a time. He heads the cardiac surgical services of the Manipal Hospital in Bangalore. Dev, welcome.
Good evening,
Dev,
sir.
your first question is, we were talking about the ventricular assist devices. This LVAD, what are the advances that are required according to you to make it more patient?
I'm always keen on kidney because I'm in this.
Hello.
I don't have any problem in my
So
kidney.
backwards,
My
sir.
diabetes is 19.
Hello, can you put all of you on the mute? Thanks. Dev, can you hear my question?
Yeah, I heard, sir. I think,
Yeah,
see,
please.
the 2 or 3 biggest concerns with LVAD, one is anticoagulation. Number 2 is the battery, charging it. And third is the console, the drive line, the infections related to that. Now, whatever advancements that have to come, probably have to come in these 3. If we can, by design or by change of material, if we can reduce the anticoagulation requirement, probably that would again improve the outcome in these patients. Number 2 would be battery. Now we know that if it is possible to
3 months or 4 months?
charge these batteries.
3 months.
All of you, please go on the mute, please. Yeah. Yes.
If we can go with like wireless charging with these batteries, probably that would eliminate the driveline and driveline related infections. Third is remote controlling. Like today, we control the pacemakers with telemetry. If we can manipulate again, get rid of the external console completely, these three things would probably increase the durability and patient acceptance. I think as far the surgeons are concerned, miniaturization probably is the way. It makes our things very simpler, like now 𝗘𝗘𝗏 2 to 𝗘𝗘𝗏 3. It has become completely intrapericardium. So miniaturization, if possible, that would also probably adds a lot.
Excellent.
The last and least, sir, is pulsatility. I personally feel that now the 𝗘𝗏𝗏 3 has some amount of versatility. If we can work on the technology where we can feel a pulse, I think the monitoring these patients and other things probably would be better. And certainly we do not know the long-term implication of pulseless versus with pulse LVAD. So pulsatility probably might add in the long run to the tissue
Okay.
performance.
Thank you, Dev. We will switch between surgeons between Bangalore and Bombay and cover some of the other current concepts and controversies. We now come to Dr. Bipin Chandra Bhamre. He is at the Sir H.N. Reliance Foundation Hospital, the consultant cardiac surgeon. Welcome, Bhamre. Can you hear me?
Thank you, sir.
Thank you. The question for you is Impella use is increasing. It's pretty costly kind of a percutaneous LVAD. The patients who come for a high risk PCI, who may fibrillate, they require some cover. Most of my cardiologists ask me that we will put an Impella. My question is that why not cardiopulmonary bypass? Because in such acute, unstable cases that we do a emergency bypass surgery, cardiopulmonary bypass, if the patient is high likely to fibrillate, do very well, and it will be much cheaper. What do you think CPB versus Impella in high risk PCI when you are thickly working with your cardiologist?
Yeah, so if the PTCA is very high risk, Impella is used as a support to the heart during the procedure. So there are a lot of options available now for Impella. We can use just a centrifugal pump with veno-arterial circuit, so that we can, instead of going on complete bypass, cardiopulmonary bypass, we can use this circuit and support the heart. Impella is itself is a percutaneous device. That is why cardiologists prefer it. But surgical point of view, lot of advancement have been done, and most of the cardiologists are not aware of this, because
Exactly.
as Dr. Devendra sir had just mentioned, that left ventricular assist device, such a wonderful devices are available nowadays, that even these class 4 patients, what we are getting very late, they can be placed these kind of devices, and we can have very excellent clinical outcome surgically. So I try to convince the cardiologist that we will use all these devices which cost around, I mean, if I use a centrifugal pump for such patient which can be placed peripherally, it will cost them only 2 to 2.5 lakhs. Impella cost is around 11, 12, 15 lakhs, depending on which kind of device they want to use.
Okay.
And
So another
yeah.
thing is talking about these LVADs, the fiscal,
Yeah.
the economical, financial problems are quite challenging. Technical aspects, what wish list already Dr. Devananda explained us. What do you think? How do we overcome these fiscal challenges?
Yeah, so right now we have available, as Dr. Devananda had suggested, this Thoratec 2 and the latest version which can be placed on intra-pericardium, that is the HeartMate 3 machine. So the price, they have come down on the second generation device, but still these devices are imported. And if we can make it, I mean, make it in India, I think
So
it will
local
be
production indigenization and a lot of
yes,
effort is
that is
going on. So that's
that
your
is
answer.
the yes, sir.
Thank you.
That yes.
And one question on the same line before we go back to Devanand. Do you think there will be truly artificial heart? And what do you guess from when you look around the world? How long will be the wait?
Yeah, so I was trained in Texas at Institute. I have worked with Dr. Fraser, and during my fellowship, we had implanted about 3 artificial hearts, total artificial hearts. It comes as a completely pneumatic device, and the patient can be ambulated. Of course, that is the ICU of Texas at Institute. But our intensive care in India also is very excellent nowadays. That is why we are able to give the one of the best results for bypass surgery, which is comparable, or I would say that better than the best hospitals in North America. So as our ICU care and perioperative care is also improving, I think this should be the way to go ahead, sir.
Okay. Now let's go back to Bangalore to Dr. Devanand. Devanand, one rapid fire few questions. One question I want to ask you that Dr. Bala and Suresh Rao taught me that the so-called neglected preoperative therapy of IABP is not to be taken that lightly or to be neglected. And they showed me in their experience that there are some patients who were unstable. They put them on IABP and some of them were on IABP for a month. And it really paid a rich dividend. And one of the patients I saw preoperative IABP really helped. If we have to put an IABP and you think I may put it for a little longer time, axillary versus femoral, any comment?
Yes, sir. I think it's always axillary which is preferred if you are looking at the longer term. One is technical easiness. Second is prevention of infection. One of the main complications we face with a groin IABP is these patients are kind of tied to the bed. If you put through the axillary, probably they can be ambulated like anybody else.
Yes.
And it's much simpler, definitely, no doubts.
Another question is
Doctor, sorry, Jawali, if I'm allowed to speak here.
Hello, sir, please.
I just want to ask Deva that, the thing is, intra-aortic balloon pump is a very weak support to the heart. So I really don't know whether there is a convincing data that it supports the heart very well. It's a we have been using intra-aortic balloon pump for many long time, but
Yes.
I am very kind of skeptically now that whether intra-aortic balloon pump is good or not.
No, absolutely agreed.
Maybe we have a miniature form of impella going from axillary artery, which we can use for a couple of days and this and that kind of thing. But intra-aortic balloon itself, to me at least, I'm not very excited.
No, I agree with you. Theoretically, you are absolutely right. People have even called it as a placebo in heart failure. But Dr. Bala, who has a huge experience, and his anesthesiologist, Dr. Satish Rao, Suresh Rao, who worked closely with us, I kind of in practice saw different picture. And that's why I asked this question to Devanand. So anyway, let's go to another question, Dr. Devanand, about ECMO weaning. ECMO weaning in cardiogenic shock, not post-surgical. Rapid weaning versus gradual weaning, pros and cons.
I think the weaning should be same standardized whether we are putting it in the cardiology or post-surgical. It also depends on for what we have put it. Like it was discussed just earlier, if you put it for an acute cardiogenic shock of say coronary region, we probably have to wait until it settles down. Same also with many other conditions. I think I do not find a difference between weaning post-surgical versus this. Basically depends on the hemodynamics. Only one comment I can probably make here is that pulmonary artery catheter, the Swan-Ganz, is something which is completely underutilized in cardiological ICUs.
Absolutely, excellent.
That's one thing which will easily guide us to see how far it is helping, apart from the bedside echoes, would guide us. I think the weaning should be standard.
I agree. And another question before I go to Dr. Bhamre in Bombay is, what is happening because we don't have too many dedicated heart failure cardiologists. The newcomers also not willing to be dedicated into the stream. So a lot of times the service depends mostly on surgeons, which is not the ideal thing to do.
Right.
How to set up a new generation heart failure team, service, personnel training, and also utilizing harnessing support from industry. What are your ideas? You have been a leader and you have
I
created
think
a
whatever
team.
we have, I think in our own shorter experience, somebody who is interested, if 2 or 3 like-minded people come together, this program probably can take off. Surgeon definitely alone cannot do this. If a cardiology support is there, very good. But minus the cardiology support, it's possible as long as we are getting the referrals for that. Point one. Now, point two is organizing services. A surgical unit, if you're looking at establishing a transplant program, first, I think we should become more proficient with invasive support like ECMO, use of nitric oxide, things which are absolutely essential when we are running a program. Third, having a good coordinator who can coordinate between these patients several times, the social worker to arrange finances, because even today in our country, the average cost of transplant in at least private setup we have seen is around 15 to 20 lakhs at least.
20 lakh practically.
Almost, sir, because couple of patients probably would get away, but 1 or 2 patients would get stuck because they have gone on invasive support like either CentriMac preoperatively or postoperatively would take away all the profits. I think in the corporate setup, I think finances are absolutely essential. So
Yeah.
looking into that, you need a social worker or a coordinator who can coordinate these aspects. When it comes to the intraoperative support, yes, if 1 or 2 surgeons are there, helping each other, one to procure, one to probably implant, is very, very essential. Imaging become very essential. If a good echocardiographer, even a technologist is fine, who can give us a good imaging either post operatively. It could even be done by our interested cardiac anesthesiologist, would go a long way. So a small team of these people would help. Immune suppression, we generally now, even today, we prefer to go with a nephrologist who probably have more than 30 years of experience in handling these medications. Many times they're better than us and the cardiologist. Because if the routine immune therapy is working, it's well and good. Now, suppose you develop complications with one of them, then to switch to others, or you develop some other complications related to immune suppression, these people already have lots of experience. Maybe we can go with that. I think a combination of this set of people would help. A role of cardiologist today would come for endomyocardial biopsy, which I think if you know Bala, I think is anesthesiologist is doing that. I think it should not be a big deal. Somebody can
Yeah.
develop it.
They have 25
So
anesthesiologists in the team.
absolutely, I think somebody can do that. It should not be a very
Most-
difficult thing.
Most
And
sorted out.
interpretation of this histopathology can be done by anybody who's seeing, even a nephropathologist who's looking into immune rejection can practically interpret these things much easily. That's what is being practiced in our center, and we have no issues with that.
We will have last 2 questions. First question, we go to Bombay, to HN Reliance, to Dr. Bhamre. Dr. Bhamre,
Yes,
now
sir.
biggest problems here in these heart transplant situations are increasing donors. 160,000 people die every year on the road, and the organ procurement from them is so poor, and also donations, religious taboos, and all kind of things. How do we improve organ donations? And number 2, how do we increase organ transportation? That will solve so much of problems and will finish waiting list. 83 centers in India are registered for heart transplant. Half of them are really good and are doing good job. So organ and transport.
Yeah, so the first thing, of course, for increase the awareness of the organ donation, because most of the families they are not aware that they can donate the heart, lungs, and kidneys, for that matter, liver and all. So it is as a clinicians, we must continuously involve in making awareness and educating the society to donate the organs, and we should give them some kind of I mean, you talked about there are some taboos in the society, whether if you go without an organ, then there will be some problem. So, from as a scientific people, we have to explain them, and that is how the donation can be increased. Secondly, coming to the transport and what we face, we are also getting some calls that the organ is available in north, in Jaipur or something, where the traveling time from these two places become kind of on the borderline of harvesting and reimplanting into the recipient. So more and more centers with the quality work can actually solve this problem. So the nowadays we are just looking at the donor and the recipients which are suppose they are registered in one place, and the donor is available maybe 1,500 kilometers apart. So the distance we have to work on so that more and more organs can be used.
Dr. 𝗘𝗟𝗧𝗛's Medivale in Tamil Nadu is working, their research organization, their devices organization is working on this heart pump or the perfusion technology in a cheaper way through the transport. Don't you think that is the way to go, to have these 4 hours extended to 8 hours?
Yes, by improving the technology, we
the
can.
cost in that indigenous technologies.
Yeah, that will significantly reduce the cost if we are using indigenous technology, and the protection of the organ will be much better during the transport.
Irritation of people like Dr. Cherian is that there is so much of push and effort going on in this country to create indigenously, and Mr. Modi's call for Make in India, but there are problems, real world problems at the regulators level. And I think that is a bottleneck, and if that is solved, I think we will see a huge burst of locally made things, and that will dramatically cut down the cost. So we come back for the last question before we close to Dr. Devananda in Bangalore. Dev, the question for you is about heart transplant versus destination therapy in elderly people, dilemma versus clinical challenges.
I think transplantation itself has got a lot of dilemma. I think especially the ethical ones, whom to give the organ. If we have a deserving patient, 2 deserving patients, but if one can take care of himself and the other fellow cannot, I'm sure it should be given to a fellow who can take care of himself, even at a fellow who is quite younger. So when we compare between the age groups, elderly versus younger one, obviously the preference has to go to the younger one. There's no doubt on that. So more elderly people probably should settle with either an implantable VAD or something as the destination therapy, which I think is accepted all across the globe. But the challenges of that again is improvements in this VAD technology is required, because you cannot put a 70-year-old or 80-year-old person on anticoagulation. It has its own challenges. So I think way probably would be to improvise the technology of LVAD, so that end of the day it is LVAD, or as we just read a year ago, xenotransplantation, if it becomes a reality in probably next 5 to 10 years, most of these problems probably could be put to an end, sir.
Because the organ supply problem
from a pig and we can implant it.
As the organ supply problem is not going to be solved easily, so the race is between xenotransplant and genetic engineering versus mechanical devices sophisticacy. So with this, thank you very much. This was a cutting-edge panel discussion discussed by the leaders across this country. Special thanks to you, 𝗘𝗟𝗧𝗛, and we come to the end of this. Thank you.
Thank you, jawali.
Good evening.
I just want to say one thing, Dr. Jawali, before we finish, that I think the time has come that we have to believe in ourselves and we have to develop our indigenous technology.
Exactly.
And many of you may be knowing definitely that Dr. Sudhir Srivastava has developed, a Indian robotic which is 5 crores of cost versus the 50 crore by Devananda. So and other devices, Indian right people, I have no doubt about it. I think we just need a new attitude that we need to develop everything indigenously.
Proof
That's
of
how
putting
we
in what
can-
you are saying. Proof of putting in what you are saying is the Merrill TAVI valve, my valve. You see,
Right.
last year India did 2,000 and odd TAVIs. 70% of them were by Merrill. So what is going to happen is we go through the maze of regulators, bring it actually to the market, and the quality is good. I think they will break all the barriers. So I think on that
Absolutely.
positive note, thank you for bringing up this point, sir. Let's close this discussion. And thanks a lot. Good night to everybody. Thank you.
Bye-bye. Thank you.
Thank you, sir.